Good afternoon. Thank you for accepting our presentation entitled The Transcriptomic Profile of Endometrial Receptivity in Recurrent Miscarriage. I will briefly discuss about the rationale behind our study and why endometrial receptivity requires further research in the context of reproductive failure. I will then describe the methods of this prospective cohort study based on endometrial transcriptomics in women with a very narrow phenotype. The results will summarize the endometrial transcriptomic profiles based on the number of previous miscarriages and based on the outcome of the subsequent pregnancies. I will conclude with the limitations and wider implications of our findings in terms of predicting the outcome of future pregnancies. Miscarriage pathophysiology is very heterogeneous. Embryonic chromosome abnormalities are the most common cause of first trimester miscarriage and account for about 40% of the cases. In addition, maternal endocrine, immunological, thrombophilic, lifestyle, or anatomical conditions may trigger some miscarriages. However, half of the miscarriages do not have a cause identifiable with the current clinical diagnostic tests. The overall incidence of embryo aneuploidy is relatively constant irrespective of the number of previous miscarriages. There seems to be an abrupt change in the cause after 4 or 5 miscarriages, suggesting the existence of a more persistent cause other than a sporadic chromosomal aneuploidy. Such a cause could be endometrial receptivity. The largest single cause of failed pregnancy is an error of implantation, the rate of which may be as high as 78% in humans. Establishment of successful pregnancy depends upon implantation, involving complex interactions between the endometrium and the blastocyst. In a recent systematic review, we identified over 50 tests of endometrial receptivity. However, none of them was accurate enough to predict successful pregnancy. Omics technologies are aimed at the universal detections of genes, messenger RNA, proteins, and metabolites in a specific biological sample. Endometrial transcriptomics identify which genes are active at a particular point in time in order to model the relative gene expression levels and to further describe the up and down regulated biological processes. The objective of this study was to characterize the endometrial transcriptomic profiles of women who suffered recurrent miscarriage and to set the foundation for the development of an endometrial receptivity test. This was a multi-center prospective cohort study performed in the setting of the Tomis National Center for Miscarriage Research in Birmingham in collaboration with St. Mary's Hospital in Manchester and the Royal Devon and Exeter NHS Foundation Trust. Women attending the recurrent miscarriage clinics at the recruiting sites were invited to participate if they were diagnosed with unexplained recurrent miscarriage based on very strict criteria. An endometrial biopsy was obtained during the window of implantation, which was timed based on the LH surge. Women were followed up until the completion of their subsequent pregnancy if they conceived within 12 months from the endometrial biopsy. mRNA-seq and bioinformatics tools were used to generate and characterize their endometrial transcriptomic profiles based on the number of previous miscarriages and based on the outcome of the subsequent pregnancy. Given the multifactorial cause of miscarriage, the aim of our very strict selection criteria was to increase the chance of an endometrial receptivity problem by excluding all other known causes and risk factors for miscarriage. Women were diagnosed with unexplained recurrent miscarriage if they suffered 2 or more miscarriages and had negative results for the investigations recommended by the ESHRE guideline on recurrent pregnancy loss. They also underwent parental karyotyping if they suffered 5 or more miscarriages. Women were no older than 35 in order to reduce the risk of egg aneuploidy. They were fertile with regular cycles and had a BMI under 35. Other exclusion criteria included risk factors for miscarriage such as lifestyle or endocrine problems, endometriosis, or having irregular cycles. This is the timeline of the study with recruitment prior to the biopsy cycle, LH testing at home, and timing of biopsy 7 to 11 days after the LH surge, which correlates with the window of implantation. We obtained endometrial biopsies from 24 women who participated in the first comparison, which was based on the number of previous miscarriages. 18 women conceived within 12 months from the biopsy and were included in the second comparison based on the pregnancy outcome. All the groups had comparable age, BMI, and endometrial thickness on the day of the biopsy. The median time to conception was 2 cycles after the biopsy. For the first comparison, we considered women who suffered 2 or 3 miscarriages in the control group, and we defined the extreme cohort as women who suffered 4 or more miscarriages based on the relative reduced incidence of embryo aneuploidy in these women. The transcriptomic profiles identified 14 genes that were downregulated and 4 genes that were upregulated in the extreme cohort group after adjustment for multiple comparisons. Gene trail enrichment analysis mapped the downregulated genes to processes related to cell signaling, adhesion, and organization. The upregulated genes are involved in inflammation and calcium transport. The second analysis compared the transcriptomic profiles of women who had a live birth with those of women who suffered a subsequent miscarriage. Over 400 genes were differently expressed after adjustment for multiple comparisons. 12 biological processes related to cell cycle and proliferation were positively enriched, while 77 biological processes related to immunity, secretion, and exocytosis were negatively enriched in women who had a live birth. This is a heat map of the top 20 up and top 20 down-regulated genes. The top half of the figure displays the women who suffered a miscarriage, while the bottom relates to women who achieved a live birth. The main limitation of these findings is the relatively small sample size. However, given the enrichment for potential endometrial problems and the inclusion of a very narrow phenotype by excluding all other known causes and risk factors for miscarriage, we believe the findings to be true. The differences based on the number of previous miscarriages may support future research hypothesis generation and may give ideas for grant applications. The ability to predict the fate of future pregnancies may have an important clinical role in terms of counseling for patients with regards to the prospect of their future pregnancies. This was the training stage for a potential endometrial receptivity test, and future validation is required in order to assess the accuracy of pregnancy outcome prediction. I would like to thank all the women who participated in this study, the recruitment sites, Tommy's Charity for financial support, University of Birmingham for sponsoring the research, and ESHRE for giving us the opportunity to present our findings. Thank you for your interest.